Right. Okay, so we're going to just pick up with fractures, and a lot of what I let me just manage. I'm just going to mute everybody here. I just to let you know, yes, I have made good progress on the videos. My husband had to be on the computer all last night, so I'm going to continue. I've uploaded some, and I will send you guys the link. So I'll have all of the lectures that I've recorded for this section, hopefully uploaded by today. They're private, but I should be able to send you the link, and then you can go and replay any of the lectures that you need to do. So, but everything I've talked about, when I talked about hip dysplasia, when I talked about stifle issues, most of all of that is genetic issues. I mean, they can have a stifle injury from a trauma. Hip dysplasia is typically always rooted in genetics, how they grew. But when I get into fractures, this is usually the result of some type of outer issue. Yes, they can have weak bones genetically that could predispose them to a fracture, but usually there's an outer reason for a fracture. So we kind of put this with orthopedic diseases. But the definition of a fracture is literally the dissolution, or that kind of think about dissolving, of bony continuity with or without displacement of fragments. So if we think about a bone, you should be able to look at a bone and trace its form, and it should be continuous. If you see any break or any disruption in the contour of the bone, then that is some type of fracture. But we're going to talk about them being pieces are either still in a line, like if this is a break in a bone, this is aligned. If I have a piece over here that is out of alignment, okay? So a fracture can be broken, but it's still together, or it can be displaced, and that's what we're going to talk about. Be familiar, this is a good slide because it talks about reasons for fractures, like why do they break a bone? It's either extrinsic, which comes from the outside, or it can be intrinsic. The reason came from the inside. Probably the most common is extrinsic. Direct violence. And violence doesn't necessarily mean like someone abused their dog, but obviously sometimes that has to be taken into account, but it can be, obviously hit by car, a direct hit by a car, or falling. A lot of times we see little whippets. They have those tiny little legs and they jump out of their owner's arms, especially in puppies, because they get wiggly and they land, and then they break their legs. So, obviously there was no ill intent. The dog fell. The cat jumped from a very high, surface and landed funny. Obviously cats are really good at landing, but there are times that cats can, break a leg if they land not the right way. And indirect violence, it can be the bone maybe was inherently weak, and because they landed, now obviously there was an internal weakness, but the reason came from the outside. There is bending, and this is when typically it's basically, think about them landing and the leg, because of the force put forward, it can actually cause a bend in the bone and a break. And torsional is if there was a twist, if they landed with a twist. So sometimes owners aren't going to be able to describe what happened, but there can be, sometimes the way the fracture looks can give the doctor a clue as to, was it a bending type fracture? Was it torsional? If we talk about compression, is typically if they jump and they come together, This can also, compression fractures can happen in the spine. So if they jump a certain way and two vertebrae compress together, can cause vertebral fractures. And then shearing would be along the axis. If you open this PowerPoint in edit view or notes pages, there's a bigger description under the slide for each type of fracture. So it does give you that information. If we're talking about intrinsic, this is usually the way the muscles push on the bones in the joint. And these are called avulsion fractures. Since we just talked about the stifle, and this is typically, avulsion fractures are typically, they're going to be more like in our younger patients, because think about that dog that's a puppy and they have growth plates, and the way they land, if it kind of pushes forward, the way the muscles attach to the bones, it can cause that growth plate to separate, and sometimes it pulls off a little bit of the bone, a little bit of the edge of the bone. So typically intrinsic or avulsion fractures are typically with growth plates, and obviously any animal under 18 months old, you know, when I talk about bone growth, is, you know, large breeds, extra large breeds are the last ones to reach skeletal maturity. So if we're talking about a Yorkie, probably around a year old, the growth plates should be closed. If I'm talking about a Mastiff, we're probably not having growth plates closed till they're about 2 years old. So somewhere in that range is where we get into these avulsion fractures. Now, pathologic fractures are typically, pathologic is, think disease. If they have some disease of the bone, obviously, I was an oncology tech, so we saw lots of animals come in with what's called osteosarcoma. And cancer of the bone, we had a dog that was supposed to come in and start radiation, because radiation can sometimes decrease the pain and decrease the swelling from osteosarcoma. But the dog, the leg was more swollen, the dog was limping extensively, and when we took an x-ray, the bone had actually fractured. So the disease ate away enough of the bone that the dog must have put weight on it. And at that point, unfortunately, we couldn't do radiation because the bone was actually broken. So a cancer, there's different cancers of the bone. Osteosarcoma is the primary cancer we see in the bone, but those animals are of a higher risk for what we call a pathologic fracture. Now, they can get osteomyelitis, which is an infection in the medullary cavity on the inside, and that can weaken the bone. So those are some important things to, you know, obviously when I first think fracture, I think hit by car and trauma, but there's lots of different reasons they can get these. Now, for example, we've already looked at this picture when I did anatomy of the skeletal system. But what we're looking at here is this bone has full continuity, okay? When we take an x-ray, we're going to look at all of these structures, and is there any disruption in that line? Some fractures are very hard to see. Some are very fine, and then some are just destroyed into pieces, and it's very apparent. But what you're looking at is all of these structures being intact. And when I talk about osteomyelitis, when I talked about hip dysplasia, and I talked about total hip replacements, anytime there is a break in a bone, there is the potential to get bacteria inside that bone. And if bacteria migrate and multiply within this bone, it can cause a inner bone infection, or it can cause osteomyelitis. And the problem is that's very hard to treat. And to get antibiotics to penetrate the bone. So often these animals are on long courses of antibiotics. It's not always successful. So we always want to try to do everything we can to prevent an osteomyelitis, because it's very hard to treat. So that's always going to be a key of any fracture therapy we do. So this is an important slide. because how do we classify fractures? One of the first things is there displacement of the segments? So when you break a bone, if you break a bone in half, there's 2 segments, okay? Now, are those segments, like I said, in line, or are they displaced? So this fracture is going to be easier to treat than this type of fracture, okay? So if the bone is broken and the fragments are in line, they are not displaced. So it is a non-displaced fracture. This is a displaced fracture, okay? And then, is it stable? And also, how many fragments? Okay, we're going to talk about 2 pieces versus 3 or more. The location, the direction, and the number of fracture lines. We're going to talk about, is the bone broken in a line across, which is transverse? Is it broken on an angle, which is an oblique fracture, transverse fracture? And then how many fracture lines do we see? One thing that you'll hear me talk a lot about is it reducible? Is the fracture reducible or not reducible? What it means, if a dog comes in and it's a displaced fracture like this, 2 pieces, can the doctor manipulate the leg and get the pieces reduced back together? So when I say reduction, fracture reduction, can we get the pieces in line or lined up? So this, I will tell you, sometimes we've had people come in with fractures and they waited too long. And what happens is when a bone breaks, it's going to start forming scar tissue. It's going to try to heal. And if that dog comes in, in 3 to 4 days, it's much harder to get these pieces back together versus we get the dog right away. So, and some fractures are just not reducible. We have to go in surgically. And then a big thing is it an open or a closed fracture? An open fracture is any puncture of the skin. It means that there is some opening from the skin to the inner part of the fracture. That could be one piece poked a tiny hole. So sometimes when a bone fragments and breaks, it might poke through the skin. And so sometimes they come in and you see this little hole. If that hole communicates to the bone, you can look at it and you can tell the difference. Is it just a skin puncture, or can you actually kind of see into the muscle and see the bone? Any type of disruption to the skin from the bone is an open fracture. It doesn't always come in and it's like gangled and you can see everything. It could be that the bone momentarily poked through the skin, and then, it doesn't mean you'll always see the bone sticking out, but at some point, a portion of the bone poked through the skin. So, and obviously, the prognosis is more guarded if it was an open fracture, because anything from the skin, like I just told you, can penetrate into the bone. So dogs with an open fracture are going to have a higher incidence of potentially, an osteomyelitis, and it's going to be more critical to get that fracture healed. Okay. So what we look at here is kind of a chart. Now, one other thing to think about is there's something called an incomplete fracture. What that means, let me go back. Well, okay. Say example, we had this bone and you saw a break on one side here. Like this, you see a line, but this side is intact. So that means that it's not completely broken on both sides. An incomplete fracture is a fracture that does not go through both sides of the bones. That's the way I think of it. So if it goes through just one side here versus one side, both sides, that's incomplete. And then the types of incomplete fractures we see, there's green stick, and that's typically seen in young patients. So green stick is a young fracture disease. And it's kind of that's very classic. They jump out of the owner's arms, okay? They land, and the front part of their bone might bend, and the front part of the bone cracks. The back part of the bone doesn't crack. And that's called a green stick fracture. A fissure might be a line inside the bone. So a green stick usually affects the cortex, or the outer part of the bone. A fissure could be a line that you see within the bone somewhere. It doesn't necessarily mean the outer portions of the bone are broke, but somewhere within that bone, we see a fissure line. And then if there's a depression, it may be that was hit by force, and you see like where lines come together, but those are all incomplete. Yes, so a fissure is like a hairline fracture. Yes, if any of you guys have injured playing sports, falling on the ice, you may have that type of fracture. And then, yes, so it's like a hairline, and that's thanks for saying that, because that's a common thing they say in people. When we get into a complete fracture, that means both sides of the bone are broken. So that means the fracture line goes through both sides. I'm going to show you a picture next, and it'll kind of explain that. But it can be transverse. Transverse is typically perpendicular to, here's the axis of the bone. This is perpendicular. So a transverse goes right across the bone on both sides. If it's complete, it affects both sides of the bone. Oblique is on an angle. So an oblique fracture is going to be a fracture through both sides, but the crack that we see is on an angle. Spiral is a little bit harder, because normally when we take x-rays, we always take two views. We take a lateral and we take an anterior view. If you compare, you'll see that it starts and it almost cracks along the bone in like a spiral fashion. I feel like spirals and obliques look similar, okay? But a spiral is going to be broken maybe up here, and then it comes around down here and breaks. Comminuted is a little bit harder, but it is going to be multiple pieces. So a comminuted is going to be multiple. Let's look at some pictures. Oh, and the other thing is open versus closed. I just explained any open fracture means that some portion of the bone probably penetrated out through the skin, and there was an open hole. A closed fracture means the bone broke inside. There's no wound to the outside. Now, I will tell you, it's hard sometimes when these traumas come in. Sometimes these dogs hit by car have road rash, and they have wounds. Doesn't always mean that those wounds communicate to the bone. The doctor's going to have to, usually we take a sterile hemostat and we poke through the holes, and can we get through the muscle to the bone? One of the worst open fractures I saw, I don't know if you guys have heard of that place, Von Licht Kennels. They train police and guard dogs, and I want to say they're up in Fort Wayne. But they train shepherds, Belgian Malinois, and they had a young Belgian Malinois, and he stuck his leg under the run to the other dog, and the other dog attacked his leg. And when this dog came in, it was basically hanging. There was multiple bite wounds, but basically that dog fractured the dog that attacked fractured the other dog's leg in multiple pieces, and you could open those wounds and you could see the bone in multiple places. So that dog had a very long road of wound flushing. We did an external fixator, which I'll talk about, but that was a pretty bad open fracture. But if there's a dog fight, teeth usually go through to the bone. So whenever it's a fracture from a dog fight, there's a higher chance that it's open. Hit by car, you might be 50-50. It just depends. But a lot of hit by cars are closed fractures because the damage stayed internal. So if I look at these, number one is the transverse. 2 is the oblique because it's on an angle. Number 3 is the spiral. So you might see 2 breaks, and then there are some fracture lines that seem to spiral. 4 is comminuted. Anytime, basically a comminuted fracture is when the bone is broken into 3 or more pieces. Do you see these first 3, this picture and this picture? There's 2 pieces, 2 pieces, okay. This one, 3 and on. Now this one, even though the fracture, it looks like there's 3 pieces, the 2 lines spiral around the bone. So really 4 and 5 are the comminuted fractures. Number 4 is a reduced comminuted. The pieces are still in line, but there's 3 pieces. And then number 5 is comminuted because there's multiple pieces, potentially with displacement. If we look at this picture, and you can see this bone is broken, and the tibial diaphysis, which is the middle of the tibia, there's an oblique fracture, but you can see on this dog, a fraction of that bone came out and poked through the skin. So this is a closed versus open fracture. And on this next x-ray, if you can appreciate this, there's no disruption to the skin. You won't always see that on an x-ray, but sometimes you can tell that it's poked through the skin on an x-ray. But this is an oblique tib fib. So this is the lateral view with the arrow. This is the AP, or anterior posterior view. Some people call it cranial caudal. The true radiographic term is anterior posterior. But if someone calls it, give me a cranial caudal view, they want you to go on the cranial aspect of the limb first. The beam goes to the caudal. So that's what that means. But you can see that this piece is hanging off the edge. There's some swelling here that you can see. Now, when we get into repair, this is a tib fib fracture. And what they used is a bone plate, bone screws, and then they used something called cerclage wire. So it's harder to see. This is the lateral view. So the plate is here. Those little lines on the side are staples. So those are the staples that are holding the skin together. Those, they look like they're inside the leg. Those are outer skin staples. But this bright white thing right here is the plate. And you can see, here's the plate. I don't know if any of you guys, you know, remember Duke. Insane. I know, it's like, who doesn't remember Duke? He had a plate and screws. The problem with Duke was his was a very distal fracture. And the problem is he's always putting weight there. So he ended up bending and cracking his plate because he's insane. And he's big. So a dog like that is going to put excess force on a plate. But plates are designed to be thick and hopefully not bend. But in a dog like that, they can bend these plates from time to time. So if you look, you can see that this bone is right there. You can see where there's a break, but those pieces are reduced. They've got it pretty close. Okay, there's maybe just a hair off, but this plate and wire and those screws should stay in unless there was a problem later with infection. But normally that plate and those screws are going to stay in and hold that together. The other thing I want to mention, and you probably don't, this has been a long time since you've had anatomy. When you have a tibia and a fibula, the tibia is the weight-bearing bone. If the fibula is cracked, and it's hard to see on this picture, but there's maybe a little disruption here. That's the back of the tibia. I'm trying to see if the fibula is broken. You normally fix the weight-bearing bone. The fibula is a non-weight-bearing bone. It's just for muscle attachment, As long as you plate the tibia, the fibula will heal via a callus, and then eventually like bony cells will come in and rebuild that bone. But you ulna need to plate the weight-bearing bone. That's the same for the radius and ulna on the front leg. If the radius is broken, we need to fix it. If just the ulna is broken and the radius is intact, you could probably just do a cast. You don't have to do much. So I will say this fibula back here, it looks like those screws go through there. They do not. Typically the screws are just through the weight-bearing bone. So sometimes on x-ray that looks deceiving, but trust me, they are only through this bone. Cerclage wire is just a metal wire, and sometimes the doctor will put it around like almost to tie two pieces together, but it helps pull the fragments. So what that's doing, that cerclage wire is helping those fragments stay together, usually while they're putting the plate on. And sometimes they leave the cerclage wire in there. So now here is a radius and ulna. So this is the forelimb. You can see it's transverse. So it's, you know, it's perpendicular. It goes right across the two bones. You can see a little break right there in the ulna. When they fix this, this is probably going to get a plate, potentially a pin, but probably a plate. And then they will leave the ulna, and the ulna will heal as the radius heals. So again, the ulna is non-weight bearing. We don't need to fix that. Now here is, this is obviously the pelvis. So this is a femoral fracture. This is a very classic comminuted femoral fracture. It's just, comminuted is kind of like, it's kind of a disaster. There's just a bunch of pieces. What the doctor will do, it's kind of like a puzzle. They're going to go in there and so obviously this is non-reduced. So this right here is completely displaced from here. It's going to be very hard to get that reduced. So we're going to go in surgically. You can see that they've used, this is called an IM or intramedullary pin. Now you guys in Animal Tech 6 get into surgeries and you talk a little bit about orthopedic instruments. So I'm not really quizzing you on orthopedic instrumentation, that'll come later. But there is an IM pin, and then there are these things called interlocking nails. So it's just another form of fixation, screws versus nails. So this is a pin, nails, and then we've got some wire. There's some cerclage wire there. These are the skin staples, okay? But you can see what the doctor will try to do is take wire and put as much of those pieces back together. It's like a puzzle. Sometimes they'll take some bone graft. They'll take some cancellous bone like from the hip, and they'll sprinkle that cancellous or spongy bone over the fracture site to help enhance healing. And again, this will take about 8 weeks to solidify. Just pop in if you have questions. This is interesting. This is showing, this was a radius and ulna, and this ended up was an open fracture. So you can't really tell from the x-ray, but these fragments punctured the skin. They put a plate on, but you can look at C. When you see right here how it's starting to turn black, okay, that's where infection started to set in, and it started to eat away at the bone healing. So right here is we've lost bony continuity, and then they had to, for letter C, it says the infected non-union is, this is 6 months later. So what happened is probably the dog became lame. They probably had heat and swelling over the fracture site. This is 6 months later. They went in and took off the plate and implants. That's probably infected. We usually send it off for culture. And then you can see there's like complete non-continuity of that bone. They went in and did what's called an external fixator. And this is where we put pins and brackets on the outside. And this frame was removed 53 weeks after the original injury. So there's 4 weeks in a month. You can talk about how long we were talking about. This is 10, 11, 11 months to heal this leg. So that's why we don't want, but again, the fact that it was an open fracture puts it at a higher risk. Whenever you close that fracture, you potentially trap bacteria. This is always potentially a risk. Okay. Now, when I talked about the avulsion fracture, this is a stifle. It might be hard to tell. There's the patella hiding up at the top of the picture. Here's the femur. Here's the tib fibula. And this little front portion of the tibial crest. Now remember, since we just talked about the stifle, all those tendons and muscles that are attached, what probably happened is there was force to this stifle, which caused one of the muscles or tendons to pull, and a little fragment came off of this bone. And it's called avulsed. And this is typically seen, again, it's hard to tell in this picture, but this line right here, that is not a fracture. Yeah, Michaela, you're probably right. I just can't math this morning, so 52 weeks. There you go. But this piece has come off. Now, what they will do, this is not a hard fracture to fix. A lot of times they will potentially put a pin through that and pin it into this bone. Sometimes they will potentially do a cast, depending on how far the piece has come off, how much pain the dog is in. I know this is an odd example, but my son was playing basketball and he was in 8th grade and he's very tall. And he came down on another guy's foot and his ankle completely went sideways. And he had a little avulsion fracture in his ankle. So a little piece, now his was not flapping in the wind. It had kind of popped off, but it was kind of still where it's supposed to be. So he was in a boot for about 8 to 10 weeks. And then that just healed. So, the equivalent of a boot that like we would wear or a cast, we can do casts, we can do bandages and splints in animals. If we think that the piece does not need like a pin, yes. Avulsion fractures, if you ever tear an ACL, anytime you can pull, if a chunk of bone comes off anywhere near the joint, so avulsion fractures typically happen near a joint because the way the joint moves and the muscles and tendons pull, you have a chance of pulling some of that bone. You have a higher chance of pulling some of that bone. So now these type of fractures, there's things called Salter-Harris fractures, and these are physeal fractures. If you think about the physeal, these are growth plate fractures. So Salter-Harris, there's 5 different types of fractures. I just want you to know Salter-Harris is a growth plate fracture. Okay, I'm not gonna add, no, there's 5 types. And they can be, they're named for where they go through. A type 1 is through the physis. A type 2 is gonna go through the physis and the metaphysis. Type 3, and it's all listed here. Let me show you the pictures, okay? So here is where we're looking at the femur coming down, or this could be the humerus. So this can happen anywhere near a joint, but you can see this gap here is the growth plate, okay? So this is the, this would be the distal epiphysis, the proximal epiphysis would be up here. Remember, the shaft is the diaphysis. So when I talk about physis, epiphysis, diaphysis, this is the epiphysis, this is diaphysis. Sometimes they call the physis this spot here, but this type 1 causes the fracture here. Type 2 goes into this diaphysis, okay? Type 3 is along the physis and the epiphysis, diaphysis, epiphysis, and then this is compression. So that means that what happened is when that bone, when that dog potentially landed or jumped or whatever, that compressed the growth plate. Okay, so if you go back, type 4 runs through the metaphysis. Wow, I can't talk this morning. This would be great for recording. But you can see that's, so when you, just to review your anatomy, the one thing I want, you know, I always think of how can I ask this question on a test? How can I make them think? If I tell you these are growth plate fractures, and if I said my 10-year-old dog has a Salter-Harris fracture, true or false? It's obviously going to be false. Michaela, it depends on the view that you're looking at the slides. If you open this view later in edit or notes, not all the slides have notes underneath, but a lot of them do. I can talk to you about that at the end. But I'm going to tell you right now, this is a young dog thing. So if I'm saying a 10-year-old dog is not typically going to get a Salter-Harris fracture because their bone plates are closed. So whenever you're, and again, bone plates close when an animal reaches skeletal maturity, which depending on the breed is going to be between 1 and 2 years old. So young dog fracture, 5 types of fractures, okay? If we look at here, so there's obviously the pelvis. So this is obviously the femur. This is a craniocaudal, which is an AP view. And this is the femoral capital physis and the greater trochanteric physis. Basically, the femoral capital physis is right where the femoral head and the femoral neck come together. It's hard to see right here because it's really dark, but we're like, where's the head of the femur? It's in there somewhere. And so the radiograph, they used a screw and Kirschner wires, which are kind of sometimes called K-wires. A lot of people say, hey, get me a K-wire. That's an abbreviation for Kirschner wire. So a K-wire pack, a K-pack, K-wire, those are used to sometimes go through bones, hold little pieces. IM pins are thicker, wires are thinner. But they're trying to close the trochanteric epiphyseal plate. The greater trochanter is right here. Our metaphysis and diaphysis. Yes, so typically the metaphysis is considered more of the middle. The diaphysis is closer to the ends, and then the epiphysis is typically the very ends. But a lot of people, I use those interchangeably. So I will make sure that I'm clear when it comes to right before the test. But basically, the metaphysis and diaphysis are like in that mid shaft of a long bone. And then the epiphyseal, you have proximal, which is high, and distal, which is low. The greater trochanter of the femur is at the neck and this little wing here. It's hard to see because it's a very dark x-ray, but that's where we're talking about. Okay, now how we reduced fractures is how do we get them put back together? Typically, if we're talking about closed reduction, that means that we are not going into the bone. So it's something put on the outside of the leg. So if we say we're going to close reduce a fracture, it means that we're doing it all by like manipulation, physical exam. So that would be like a splint. You could do a cast. Like I said, sometimes you could just do a very thick bandage. But a splint is usually a mold. We have some splints. You guys will get into splints in Animal Tech 6. We have some at school. We have different types of splints. But basically, you know, the problem is in people, you know, if you do a bandage or a cast, we're very good about taking care of it, not getting it wet, not doing too much activity. I personally think casts and splints and bandages are a nightmare, because getting clients to cover it when the dog goes outside, don't let the dog play in it. I mean, I've had them come back almost black with dirt. And I was like, have you covered this splint? And it comes in all tattered and torn. Um, so, um, but anytime, what I want you to know is fracture reduction, I would probably ask you, what is the difference between open and closed fracture reduction? Closed means we did something from the outside. We didn't open up the skin and muscle and access the bone. Obviously, an open reduction means we're surgically going to open the leg or open the limb, and we're going to apply some type of internal fixator. Okay, that's the bone plate, the IM pins, the cerclage wires, screws, K-wires. You can even put interlocking nails on there. Most of my surgeons did not use interlocking nails. They mostly used what's listed here. But open reduction means you got to open the leg, if you want to think of it that way. If I look at this picture, okay, so here's an example. Here's the limb. That's a very deformed looking paw, weird picture. That they've basically put some type of cotton thick padding. Sometimes we wrap this 3 or 4 times. There's different types. Animal Tech 6, you do bandaging. You talk about different types of bandage material. Okay, but what they're trying to do is keep the leg in line. If this bone was broken, bandages and splints are good for those incomplete fractures or non-displaced fractures. So if you have a very simple transverse fracture, you could probably put a splint there, no big deal. If it's in a bunch of pieces, you're going to have less success with this. On this side, you can see sometimes what they'll do is we don't always put the leg straight out. Sometimes the splints will allow the leg to be in maybe its normal bend position. And what happens here is you have the splint and you have some sticky tape to kind of wrap it around the limb. Usually the splint is only on one side. A cast can go around the whole leg. A splint is always on only one side, and it needs to be on the weight-bearing side. And then there's usually bandage around the splint, some type of like cotton wrap, and then you've got like maybe vet wrap. Here's an example. This is kind of a very strange splint. Normally the splints that we use, we put inside the bandage. This dog is bandaged, and then this splint, but do you see how the splint is on the back of the leg? Because when the dog places their paw, the weight is shifting towards, they don't go forward on their leg. When they stand, they put weight caudal. So normally any splint is usually put on the caudal aspect of the limb. And on this picture, this is what's called a spoon splint. The end looks like a spoon. So the paw would go into that. Usually we put some padding, and then we will wrap around the limb and get that wrapped. I'm going to show you this picture briefly. This, I hate these. Animals with external fixators are very hard to manage, but if we look at this bone, these are used sometimes for, these are usually for infected. So if it was an open fracture, a lot of times, we did this for the dog that I just talked about that got attacked by the dog at the training facility. We put on an external fixator, except that was a 1-year-old Belgian Malinois. The dog was literally insane, like a pogo stick. And when they've got this giant chunk of metal flying around, I mean, I've gotten these bumped into my leg. They don't feel great. Normally, these are going to be wrapped. Whenever we put one of these on a dog, we usually wrap the ends with bandage material so they're not like going home and destroying their owner. But you can see in the picture, the pins are arranged in different ways, and those little clamps can be pulled and twisted and can adjust the angles of the bone. So normally we will take x-rays several times. Here, now, let me explain. This picture is a dog. If you can see, he's kind of a shortcake and his legs are a little twisty. Sometimes in Bassets or these short-legged dogs like a Lhasa, they'll get what's called angular limb deformity. It means that their bone grew kind of like a curve at an angle. You could potentially leave a dog like that, but the problem was in severe, you can see right there, that carpus, it's gonna put a lot of abnormal wear on the carpus. It's gonna cause arthritis. So sometimes we will go in, surgically break the leg, put on a fixator and twist the angle of the bone and have it heal in a more normal position. So when we fix angular limb deformities, we go in and break the bone surgically and then move the pieces around. When we look at an external fixator, this is one that has just been placed in surgery. This incision up here could have been from a trauma. It could have been from a bone graft. They made an incision, took some of that cancellous bone from the closer to the joint, and then put that on the fracture site. But here you can see the pins. This dog was not, the skin was not open during surgery. There's an opening there was probably a wound. So I'm gonna guess this was some type of maybe trauma. And they drilled the bones through, or they drilled the pins through the bones, and then they apply these clamps. And then post-op, we wrap all of these clamps so we don't have metal just showing. It's also to protect the dog. If the dog bumps that kind of hurts the leg. So we want to provide some bumpers or padding. And then the thing is, this dog has to come in periodically. Usually that dog, once a week, we sedated it. It was my job to unwrap it. I had to clean around all the pins. I would take sterile Q-tips and saline and Chlorohex, and I'd scrub all the little pins, and I'd put like Neosporin at every site, and then I would rewrap the leg after the doctor adjusted the clamps. So it usually took us almost an hour every time he came in that week to clean the pins, take an x-ray, rebandage, wake him up from sedation. So they're a little bit time consuming and harder to handle. Since I'm going to end here today because I want to get into a little more of the other repairs tomorrow. Actually, let me do something.